The elderly person's body looks like this 1 month before passing away. Hello, I'm Dr. and welcome back to Saúde Integral. Today we must discuss a profoundly sensitive, often feared, and widely misunderstood topic, the final phases of life, specifically addressing the question many of you have asked me in private: what verifiable changes happen in the body of an elderly loved one in the window of approximately 1 month before they pass away? This is a conversation that requires compassion, but it also requires extreme clarity and directness. Too often, fear blinds us, and we spend our final precious weeks with a loved one searching desperately for a magical cure or a sudden medical alert, when in fact, the body is simply and naturally beginning to conserve energy. I want to dismantle the myth that there is a single, dramatic, secret sign that suddenly appears on a calendar day. The transition is rarely instantaneous. It is, almost universally, a slow, quiet, and highly personalized process of physiological withdrawal. Understanding these subtle shifts is not about predicting a specific date. It is about shifting our focus from fixing to comforting. Let me share a story with you, one I've seen repeated countless times in my practice, involving a patient I'll call Mr. George and his daughter Lisa. Mr. George was 95, suffering from advanced COPD and chronic heart failure. Lisa was his primary caregiver, tireless and loving, but absolutely terrified of missing the moment. About 5 weeks ago, before she contacted me, Mr. George was still watching his baseball games, eating half his meals, and walking slowly to the mailbox once a day. But then, a definite change occurred. Lisa called me in hysterics. She said, "Doctor, he has given up. He hasn't touched a full meal in 3 days, he's sleeping 20 hours a day, and when I try to talk about the grandkids, he just nods. Is this it? Is this the sudden crash?" I understood her terror. Lisa was looking for the loud siren. She was looking for a catastrophic event, a massive fever, uncontrollable pain, or a major medical crisis. But what she was witnessing was the body's natural, internal reorganization, the beginning of the terminal phase. We had a long conversation about what those 3 to 5 weeks typically entail. First, we discussed the dramatic reduction in appetite and thirst. This is perhaps the most confusing and upsetting sign for caregivers. Lisa felt she was starving her father. I had to explain that, as the body prepares for the end, its metabolic needs plummet. The digestive system requires immense energy to break down food. When energy is scarce, the body turns off unnecessary systems. Hunger and thirst signals fade, because the body is no longer utilizing those resources. Trying to force calories or large amounts of fluids in this stage often causes more distress than comfort, leading to nausea, vomiting, or fluid retention. George's preference shifted from hot, solid meals to sips of cold apple juice or small spoonfuls of ice cream. This was not giving up. It was his physiology taking over. Second, we focused on the overwhelming somnolence, the profound desire to sleep. When Mr. George was sleeping 20 hours a day, Lisa thought he was depressed or heavily medicated. I assured her that terminal fatigue is central to this phase. His body was using every available joule of energy internally. Staying awake, socializing, or even performing small motor tasks had become unsustainable metabolic efforts. His waking moments became brief, gentle periods, focused solely on immediate comfort and connection, not conversation or activity. Third, and most difficult for Lisa, was the subtle withdrawal and change in communication. Mr. George, who loved to tell stories, started responding with single words or noncommittal gestures. He wasn't being rude. His brain was diverting cognitive energy. The focus narrows to the immediate environment: comfort, warmth, sound, and touch. The ability to plan, remember complex details, or engage in lengthy conversations often disappears about a month before the final days. My role was to help Lisa stop fighting the process and start joining it. We established a hospice care protocol focused entirely on dignity and pain management. We shifted from asking, "How can we make him eat?" to, "How can we make him comfortable right now?" The crucial takeaway I want you to internalize is this: the final month is typically defined by a shift in priorities. The body moves from survival, fighting the disease, to conservation, preparing for rest. If you are witnessing these shifts, the profound fatigue, the refusal of food, the subtle cognitive changes, I understand the fear that grips you. You worry you're failing them, or that you missed a window for intervention. Please know this: your fear is valid, but your loved one is not failing. They are progressing naturally. In the upcoming parts of this series, we will delve deeper into the specific physiological markers, how vital signs change, the realities of skin integrity, and managing the anxiety that accompanies terminal restlessness. But for now, hold on to this foundational knowledge. The decline in the final month is marked by conservation, not collapse. And our greatest duty is to understand these signs so we can offer acceptance and unwavering dignified comfort. We left off discussing acceptance, the core emotional component of the final decline. But to truly accept what is happening, we must understand the mechanics. What is the body actually doing in this critical month? This period is not characterized by a sudden catastrophic collapse, but rather a profoundly intelligent biological conservation of energy. Think of it less like a machine breaking down and more like a massive factory complex slowly and intentionally powering down, diverting the last stores of fuel only to the essential command centers. The first and most noticeable change is in metabolism and the body's relationship with food and water. In the final month, the central control system, the brain, receives signals that the entire system is operating at critical reserves. Survival instincts shift from long-term maintenance to immediate comfort and minimal expenditure. This manifests as a severe reduction in caloric need, often referred to as the anorexia of aging reaching its terminal phase. Your loved one is not refusing food because they are being difficult. Their body simply no longer requires the energy, nor can it efficiently process it. When we are healthy, we use a lot of energy digesting food. In the end-of-life process, diverting blood flow and energy to the digestive tract is considered an unnecessary luxury. Forcing food or high-calorie supplements at this stage is medically counterproductive. It increases the risk of aspiration, food or liquid entering the lungs, which causes discomfort, congestion, and distress. Furthermore, a common concern among caregivers is dehydration. This is where clarity is essential. In the final weeks, dehydration is often a protective physiological mechanism, not a cause of suffering. A reduced fluid intake means reduced fluid volume overall. This translates to less urine output, reducing the need for bathroom visits, which can be incredibly taxing and painful. Critically, it also reduces fluid accumulation in the lungs and extremities, minimizing the shortness of breath and painful swelling that often accompany severe heart or lung disease. We are observing a biological mandate: simplify the internal environment. Now, let us discuss the circulatory and neurological shifts. As the system conserves energy, the heart does not need to pump with the same vigor. Blood pressure naturally lowers. Circulation becomes less efficient, primarily prioritizing the core organs. This poor peripheral circulation is why the extremities, the hands, feet, and legs, often feel cool to the touch and may begin to show mottled bluish-purple discoloration. This mottling often starts in the feet and moves slowly upward. It is a reliable external sign that the body is internally consolidating its resources. Simultaneously, the nervous system begins to withdraw. Profound fatigue and increased sleep dominate the day. This is the body's way of reducing external sensory input. The world, the light, the noise, all become stressors that require energy to process. By sleeping more, the brain is minimizing its workload. Communication may become more challenging, and wakeful periods are often short and focused, requiring immense concentration from the elderly person. Understanding these biological steps leads us directly to the crucial question: what causes this final shift? Is it merely accelerated aging, or is there a specific trigger? This is the distinction that defines good geriatric and palliative care. Normal aging lowers the body's reserve capacity. Imagine a battery shrinking from 100% capacity to 20% over 80 years. Death, however, is caused by a stressor that overwhelms that remaining 20% capacity. The stressor is almost always a chronic disease that has reached its end stage: severe congestive heart failure, advanced COPD, end-stage kidney failure, or refractory dementia. Aging makes the system fragile. The disease is the weight that finally breaks the fragile bridge. And this brings us to a major cause of distress and confusion in the final month: polypharmacy. Polypharmacy means the use of multiple medications, often 5 or more for chronic conditions. When the body enters this conservation phase, the cocktail of medications designed for long-term prevention, the statins to prevent a heart attack 5 years from now, the high-dose blood pressure pills, the supplements meant to fortify the system, becomes a metabolic burden. Imagine you're trying to close a large restaurant gracefully. You don't need all the kitchen staff running around trying to prepare new menus. Polypharmacy is like having too many chefs in a kitchen that is shutting down. They only create chaos, metabolic stress, and unnecessary side effects. When the kidneys and liver are slowing down, as they do in the final month, these medications build up to toxic levels. A blood pressure pill that was perfectly fine 6 months ago might cause profound, debilitating weakness today. A diabetic medication that managed blood sugar is now causing dangerous lows because the patient is barely eating. Therefore, one of the most proactive and loving things we do in the final month is called deprescribing. We systematically stop medications that are no longer serving the patient's goal of comfort and dignity. We eliminate preventative medications and focus solely on symptom control, pain relief, anxiety management, and addressing nausea. The direct message here is this: if your loved one is on numerous medications, work immediately with their geriatrician or palliative team to review every single pill. Which ones are truly mandatory for comfort right now? The ones designed for prevention or maintenance must usually go. They are actively contributing to the decline by placing stress on organs that are already struggling to conserve power. In summary, the month leading up to the end of life is a time of intelligent biological simplification. The body is making a conscious retreat, reducing energy expenditure, prioritizing vital core systems, and withdrawing from external stimuli. Our duty as caregivers is not to fight these biological mandates by forcing food or pushing unnecessary medical treatments. Our duty is to recognize the process, simplify the environment, simplify the medicine cabinet, and ensure the entire remaining journey is marked by absolute comfort and dignity. Understanding this physiological truth allows us to release the anxiety of what if they starve or what if they are thirsty, and focus completely on the true mission, being present, gentle, and simplifying the remaining time. If you've been following the Saudi Integral channel, you now understand the fundamental physiological truth of the body's final phase. The system is designed to shut down peacefully. The anxiety surrounding forced feeding or aggressive hydration must be released, replaced entirely by the mission of comfort. Now we move from theory to action. This is your practical protocol for ensuring that the final journey, which may take weeks or sometimes just days, is marked by absolute dignity, minimal pain, and profound presence. The single most critical step you must take is ensuring professional palliative care or hospice involvement. If you are reading this, and this team is not yet fully integrated, stop everything and coordinate that immediately. We, as medical professionals, provide the structure, but the daily execution falls to the caregivers. Let's dissect the 4 essential pillars of the final month of care. Pillar 1, proactive symptom and pain management. This is the non-negotiable foundation of comfort. We do not wait for the patient to rate their pain on a scale of 1 to 10. When communication is compromised, we anticipate and prevent. 1. Pain control, the opioid reality. In this final phase, fear of addiction to pain medication, such as morphine, oxycodone, or fentanyl, is entirely irrelevant. These medications are not meant to prolong life or hasten death. They are used solely to control suffering. The use of opioids, when correctly titrated, is an act of profound compassion. You must have the scheduled dose and the rescue dose readily available. The scheduled dose keeps the baseline pain down, but if you notice grimacing, restlessness, increased heart rate, or refusal to be moved, administer the rescue dose immediately, as prescribed by the hospice physician. Never hesitate out of fear that the medication is too strong. Strong medicine is necessary for strong pain. 2. Managing anxiety and agitation. Dyspnea, restlessness. A great deal of discomfort comes from breathlessness or anxiety, terminal restlessness. Medications like lorazepam or midazolam are crucial here. These benzodiazepines ease the anxiety that often accompanies difficulty breathing, dyspnea, and prevent the patient from panicking. If the patient appears agitated, pulling at their clothes or sheets, do not assume they are simply confused or trying to move. Often, this is a manifestation of physical discomfort or fear. Use the prescribed medication to calm the central nervous system. 3. Addressing secretions, the terminal rattle. As swallowing reflexes diminish, fluid and mucus can pool in the throat and upper airway. This is what we call the death rattle. While often not distressing to the patient, who is usually semi-conscious, it is profoundly distressing to the family. We manage this proactively with anti-secretory drugs, such as scopolamine patches or atropine drops. These medications dry up the secretions. A critical note: do not reposition the patient aggressively or try deep suctioning. Deep suctioning can cause immense distress and pain. Simply position them gently on their side to allow gravity to assist drainage and use the anti-secretory medication. 4. Bowel and bladder care. Since powerful pain medication, opioids, causes constipation, a protocol for maintaining soft bowel movements is mandatory, even if the patient is consuming very little. Regular stool softeners and gentle laxatives must be continued to prevent a painful impaction. For bladder function, if the patient is uncomfortable, the physician may recommend an indwelling catheter to ensure continuous comfort and cleanliness, minimizing the need for constant changing and movement. Pillar 2, nutrition, hydration, and oral care. This is where the physiological lesson from our last discussion becomes essential. We are not feeding or hydrating for nutritional needs. We are managing the sensation of dryness. 1. Respecting refusal. If the patient refuses food or drink or takes only a few sips, this is the body's natural process. Do not force, coerce, or plead. Forcing liquids or solids can lead to aspiration, choking, or pneumonia, which is extremely painful and counterproductive to our mission of comfort. Respect their limits. This refusal is a form of communication. 2. The power of oral care. The mouth and lips dry out rapidly in the absence of swallowing. This dryness is the primary source of discomfort, regardless of the patient's overall hydration status. Your job is to keep the mouth wet, soothing, and clean. Swabs. Use specialized oral care. Swabs, or touthettes, dipped in water or a mouth moisturizer every hour or two. Gently wipe the inside of the cheeks, the tongue, and the roof of the mouth. Ice chip sips. Offer small, crushed ice chips or tiny sips of their favorite drink, juice, weak tea, if they are alert and capable of swallowing safely. If the cough reflex is weak, stick to the oral swabs. Lip care. Use lip balm or petroleum jelly constantly to prevent painful cracking of the lips. The sensation of a clean, moist mouth provides immense psychological and physical relief. This is often more effective than intravenous fluids. Pillar 3. Environment and positioning. Immobility leads quickly to skin breakdown, pressure sores, and pain. Your goal is to keep the patient physically comfortable and minimize the stress on their skin and muscles. 1. Turning schedule. Skin integrity. The patient must be repositioned gently at least every 2 hours. This is non-negotiable. Use pillows to support the body, ensuring that bony prominences, heels, hips, tailbone, shoulders, are protected and floating, not pressing onto the bed. If possible, acquire a pressure-relieving mattress, a specialized alternating air mattress, or a thick gel pad. These tools dramatically reduce the risk of painful pressure ulcers. Inspect the skin, particularly the lower back and heels, multiple times a day. If you see redness that does not fade quickly, that area is in distress. 2. Range of motion, passive movement. Gentle, passive range of motion exercises are helpful, but only if they do not cause discomfort. Simply flexing and extending the arms and legs slowly can prevent stiffness and improve circulation, provided the patient does not resist or show signs of pain. Minimize unnecessary transfers or efforts that require the patient to exert themselves. The goal is rest and conservation of energy. 3. The sensory environment. The environment must be calming and familiar. Lighting. Keep the light soft and indirect. Harsh light can be agitating. Noise. Minimize sudden, loud noises, but maintain a gentle, continuous background sound that is familiar. Perhaps their favorite classical music, or the sounds of daily household life slightly muffled. Silence can sometimes feel isolating. Touch. Touch is vital. Hold their hand, stroke their forehead, and perform gentle massages using unscented lotion on their back or feet. These gestures communicate love and safety, even if they appear unconscious. Pillar 4. The caregiver's emotional protocol. The journey is exhausting, both physically and emotionally, for the caregiver. You must remember this. Your presence is the most powerful medication you possess. 1. Auditory comfort, the last sense. Medical evidence strongly suggests that hearing is the last sense to leave. Assume that the patient can hear you, even if they appear deeply unconscious or unresponsive. Speak clearly, calmly, and maintain eye contact if they are still able to focus. Share memories, tell them you love them, and explain what is happening simply. If the patient is restless or agitated, the sound of your voice, steady and reassuring, can be incredibly grounding. 2. Permission to go. This is often the hardest, most necessary act of love. Sometimes a person will seem to linger, waiting for a perceived permission. If you are feeling immense guilt, or if there is unresolved conflict, the patient may subconsciously hold on. In a quiet moment, assure them that everything is resolved, that they are loved, and that it is all right for them to rest now. You will be okay. Give them your explicit permission to release the struggle. This can bring surprising and sudden peace. 3. Caregiver support. You cannot pour from an empty cup. You must take breaks. Use the hospice team for respite care, even if it is just for an hour to step outside, breathe, or eat a proper meal. Fatigue leads to mistakes and resentment. This is a marathon of love, not a sprint of obligation. The goal of these final weeks is not to manage a disease. It is to manage a sacred passage. By applying this comprehensive protocol, focusing intensely on pain management, meticulous oral care, gentle positioning, and unconditional presence, you ensure that the end of life is not a medical crisis, but a peaceful conclusion to a life well lived. Remember, comfort is not a sign of giving up. Comfort is the highest quality of care we can offer. Be present, be gentle, and trust the process. We have covered difficult yet essential ground today. We detailed the body's final blueprint, the natural slowing down, and clarified that these changes, such as reduced appetite, increased sleep, and shifts in circulation, are not signs of failure, but rather the system wisely conserving energy for the final journey. I want to pivot now from the physiology of decline to the philosophy of dignity. If there is one thing I hope you take away from this conversation, whether you are preparing yourself or supporting a loved one, it is this: comfort is the highest form of care we can offer. Once we shift the focus from cure to comfort, a profound peace often descends upon the room. Recap the key points we discussed earlier. First, let go of the need to force nutrition. The reduced desire for food and drink is the body's way of ensuring comfort. Pushing fluids or meals at this stage often creates discomfort and anxiety, not sustenance. A tiny ice chip moistening the lips Or careful mouth care provides far more benefit than a large meal. Trust the body's wisdom. Second, embrace the silence. The increase in sleep, sometimes 20 hours a day, is not withdrawal. It is necessary rest and release. Use these quiet moments not for panic, but for peaceful presence. When they are awake, talk normally, hold their hand, and share stories. Remember, the sense of hearing is often the last to go. Never assume they cannot hear your words of love, gratitude, and goodbye. Third, maintain gentle positioning. Simple adjustments, soft pillows, and careful turning prevent painful pressure sores and maximize breath comfort. This requires patience, not complex medical maneuvers. It is the simple, repetitive acts of deep care that matter most now. Now, let us discuss dignity, the non-negotiable principle during the end of life. Dignity means honoring the person's identity until the very last moment. For the caregiver, this often means letting go of control. You cannot control the timing of death, but you absolutely control the quality of the farewell. Dignity means minimizing medical intrusions and maximizing human connection. It means ensuring pain is managed aggressively and that the individual is treated with the utmost respect, always speaking directly to them, even if they appear unresponsive. I know many of you watching, the sons and daughters, carry immense guilt. You worry you didn't do enough, or you question if you're giving up too soon by shifting to palliative care. I need to be direct with you. If you are prioritizing their comfort, their peace, and their presence, you're doing exactly what you should be doing. You are not giving up. You're graduating to the highest level of human care. The greatest gift you can offer now is not more medicine, but unconditional presence and acceptance. This time is sacred. It is the summation of a life. Do not let fear or medical confusion overshadow the profound opportunity for connection, forgiveness, and love. Understand that the end of life is not a medical crisis, but a final natural conclusion to a life well lived. By focusing on comfort, dignity, and the profound power of your presence, you ensure that this conclusion is as peaceful and meaningful as possible. If this conversation brought clarity or comfort to you, please take a moment to subscribe to the channel. Sharing this video might help another family struggling to navigate these inevitable, powerful moments. My promise to you, as your geriatrician, is always to bring clarity and compassionate expertise to the complexities of aging. Be present, be gentle, and trust the process. Until next time, take good care of yourselves and your loved ones.